This is Jerry Hesch. I'm an orthopedic manual physical therapist. I specialize in treating joints throughout the body. And my client Jonathan flew in from Indianapolis. He had labral repair and a cam lesion, a deformity of the hip joint, repaired on both hips. He had a very slow recovery, challenging recovery on the right, still has right-sided anterior upper thigh pain in the region of the hip joint. He has an uncle who has ankylosing spondylitis, and on his mother's side there is a history of some arthritis. I bring this up for the simple fact that I cannot get any mobility on the right, through the right sacroiliac joint. On the left side, I can load the ilium and you see the whole pelvis move. With that, take up the motion. It's called taking up the slack. And I then can spring it. So once again, I push it to an end point where motion stops. And then I need an additional amount of force to induce motion. And it thrusts forward and it recoils backwards. On the right side, I'm doubling that force. I'm tripling it. I'm putting a lot of force through the pelvis, and I'm not getting any motion. Let's have you lie on your stomach. So on the left side, I can take up the slack and I can spring and get motion. And I can do that in multiple directions on the left side, in rotation as well, and springing through the ischium as well. On the right side, nothing. There's no inferior motion, and I'm putting a lot of force, a lot more than would be necessary, and a lot of vertical force, and there's no give whatsoever. Now, is this right sacroiliac joint fused from an inflammatory arthritic condition? I think not. And the reason I think no is noting there is asymmetry of this pelvis as well, right side relative to left. The sit bone looks lower. The sacrotuberous ligament feels like rock or bone. It's just very, very hard. In comparison to the left side, I can indent the left sacrotuberous ligament. I cannot indent this one. It's just too hard. So if the ilium slipped down, called a downslip ilium, that would put tension on the sacrotuberous ligament. If his right sacroiliac joint was fused, then when I spring the joint on the sacrum at S1, S2, and S3, I would expect no motion on the right side. I can take it the slack, and I can thrust it, and that force goes through the sacroiliac into the hip, and I see his feet move. So because the sacrum has mobility, then I don't think this is a matter of the sacroiliac being fused. So it looks like, positionally, it looks like ilium slid down and rotated forward. Okay? You know, and these are subtle findings. This landmark is less subtle. His iliac shelf on the right, you know, is distinctly higher. The thing that would make it higher would be an anterior rotation. Okay? So I'm going to treat him by pushing this hemipelvis up. And I'm going to see what we achieve with that. And the technique I use is very simple. Lie on your back, please. And scoot down so your feet are off the bed. Good. And so the technique that I use when the therapist induces the treatment, and then I teach them a self-treatment, so it's only a one-time intervention on my part, is what I do is I look for what angle of the hip can I use to induce a little bit of superior mobility. There's no motion happening at this angle. Okay? Then I bring his hip into about 10 degrees of abduction. There's no movement. The typical angle is about 10 or 15 degrees of adduction, A-D-D-U-C-T-I-O-N, bringing the foot past the midline. And now I can I can push up through his leg and I see motion going beyond the ilium. So in this angle, I can get force transmission through his right sacroiliac joint. So this is the angle that I'm going to use, and I'm going to lean on him like this and set a timer for 5 minutes. So we will then come back and film his response to this.